Okay, so welcome everyone to this webinar. I am so excited about this webinar. I love the title, and I was discussing also with Rute about the title. I will let you know what we were discussing after. Just let Ruth go through this very interesting topic, fitting scleral lenses without technology, simplifying the fit. So, just to introduce you to Ruth. Ruth Araújo is a PhD in optometry and vision science at the University of Minho Braga in Portugal, and she is an invited lecturer in the Department of Physics of University of Minho and a research assistant at Clinical and Experimental Optometry Research Lab since 2013. Her investigation is focused on contact lenses, mainly scleral lens fitting for visual rehabilitation, but also optical quality of the human eye, electrophysiological response of the human retina, and light disturbance analysis. Very complicated cases, Ruth.
Yeah.
She has several publications in peer-review ISE journals, is author of several communication in national and international conferences, and is a co-author of a book chapter. Thank you so much, Ruth, for being here and for sharing your knowledge. The stage is yours.
Thank you so much, Daddy, for the introduction. So, yeah, so I think I don't need to introduce myself further, but yeah, I'm an optometrist and a clinical researcher. I'm passionate about simplifying the scleral lens fitting and make science more accessible to everyone. Also, some fun facts. I'm an animal lover. I'm a proud owner of Oreo and Freddy. And another fun fact is that, yeah, optometry wasn't my first career choice. Social media or social communication was. But yeah, probably in another life, you would see me presenting the news or the weather on national TV. But yeah, of course, life had another plans for me, and I couldn't be happier to be here with you doing what I love every day. So of course, I'm very happy to be here today with all of you. And being where I am today is only possible thanks to my work, of course, but also because I'm surrounded by inspiring people who challenges me to be better and who give me incredible opportunities and support to present my work. So I want to tell here to everyone that I'm eternally grateful to you, Daddy, but also to many other people. One of whom I must highlight is José Manuel Meirome from my university. So thank you, thank you, thank you. I am truly grateful to have you in my life. But it's not about that what I'll be talking today. Here is a table of contents that I will try to follow over the next hour. So, just an introduction. In a work that I've done for my PhD thesis, it's not published, but this was an online survey in Portuguese. And so it was possible to include practitioners from Portugal and Brazil. And I asked them if they already fitted some scleral lenses. And for those that said that didn't fit scleral lenses, I asked for the motives to never have fitted. And the great majority said that they didn't have enough training to fit them, or never had a case in which they considered that a scleral lens fit was necessary. But one interesting thing is this one. More than 70% of those who never fitted scleral lenses said, I don't have advanced equipment to do a scleral lens fitting. And my question here is, so we really need high technology to fit scleral lenses? And this one leads to another question, that is, what actually qualifies as high technology in scleral lens fitting? And this one is for you to answer. So Daddy, can you please put the link on the chat group. And for those who can, you can scan this QR code. I will activate the question. Okay, so you can scan and write what you think that high technology in scleral lens fitting. What is high technology? So I'll wait.
Yes, I'm putting the link here.
Okay, thank you. So I'll wait some time for okay, anterior OCT experience. Oh, I love that. Profilometer, yes, like scleral topographers, topography and OCT. Okay, yeah.
Just 1 second.
Yeah.
Okay, everyone has it.
Okay, thank you. Okay, many people saying OCT, some saying topographer, either corneal or scleral topographer. I will put a star in this because it's very different experience, and you will understand why I'm I'm putting highlight this one. But yeah, high-tech OCTs, specular microscope could be also good to have one. Yeah, we will see why. Scleral topographers, impression technique, pentacams, etc. Well, so probably we can consider that high technology is when you have to pay money to have that. But yes, I'm telling you that you can have success in scleral lens fitting without all that fancy devices. But of course, it is true that these technological advances have helped a lot to increase our knowledge. So helping in research, studies, etc., to have more knowledge about the anterior ocular surface, etc. And of course, these have made the process of fitting much easier. But we need them to fit the lenses in the same work that I showed before. I asked those that already fitted scleral lenses the equipment or the devices they had available. And almost all of them say they had available slit lamp and fluorescein. Some said OCTs and corneal topographers, and almost none said that they had access to scleral topographer, pachymeter, a barometer, etc. So I'm here to simplify your work, to work with the tools that you already have on your practice. So refraction tools, slit lamp, fluorescein, corneal topographer is not essential, but yeah, we will see that can help a little bit in some cases, but is yeah, we can remove the corneal topographer from here. And if you are not a scleral lens fitter, you will need to have some more things. Of course, trial sets, plungers or other kind of scleral lens handling tools, preservative-free saline solutions, and the most important, knowledge. And how to have this knowledge? Of course, there are a lot of webinars like this one promoted by the Euroschool, also workshops. Also in Portugal, there are some courses in the University of Minho that can help you in advanced contact lens fitting. There are some resources that are free and you can download it online, and also some books from Daddy Fadel and other authors that you can order online as well. And this will help you to have knowledge. After the knowledge, you will have to practice. Yeah, and I in the next slides I will show some things for you to understand the basics of scleral lens fitting and how to gain experience. But before that, and to to know a little bit more about the people that are here, I want you to tell me if you already fitted scleral lenses and how. Okay. Let's see. Okay. Okay, so we have here some experienced practitioners and some unexperienced practitioners, which is good and it's not good because it's difficult for me to to take these all in one presentation. So I will talk about some basic things for those who never fitted sclerals or have fitted very few sclerals. And I'm sorry for the experienced ones, but yeah, we need to help people to achieve success, more success with scleral lenses. So about scleral lenses. So these are large diameter rigid gas permeable lenses that land exclusively on the sclera, and they vault all the cornea and all the limbus without touching these surfaces. So these make these lenses incredible, comfortable for the patient because they do not touch the corneal surface. So with this lens, we can avoid that sometimes painful sensation that corneal RGP lenses can make patients feel. So these lenses need to be applied in the eye with liquid, and this needs to be preservative-free saline solution. And as this liquid will be in touch with the corneal surface throughout the day, it is essential to be preservative-free to avoid some complications. And this will also allow to mask the corneal irregularities and to moisten the ocular surface. So about the indications for the scleral lens fitting, there are a lot of indications. We can divide them into three major categories. So visual rehabilitation for corneal ectasias, those that are primary like keratoconus, or secondary ectasias, and all kinds of corneal irregularities, and also for those patients that have healthy eyes or healthy corneas. So no pathological metropias like eye astigmatism, etc. So in this slide is from a work that have been done here in the University of Minho, where I'm sorry, where we fitted patients with scleral lenses. We fitted 55 patients with irregular corneas and 14 with healthy corneas but high refractive errors. And in these graphics, we can see here HC is the habitual correction of the patients that they have prior entering the study, the best spectacle correction that we measured in the baseline, and then the visual acuity with scleral lenses. Mine that is in the logMAR scale, so the more close to 0 will be better visual acuity. And we can see that the red and blue bars, so the irregular and healthy corneas, improved visual acuity. Of course, in the healthy corneas, the improvement it's not statistically significant, but for those with irregular corneas, the improvement is very high. But what I need to highlight here is that the visual acuity in high contrast was very similar between people with irregular corneas and people with healthy corneas. But when we measure it in low contrast, patients with healthy corneas had better visual acuity than the ones with irregular corneas, because some residual aberrations that remain after the fitting, etc. But this is something to keep in mind. And also follow up on the next Euroschool webinars, because there will be one about correcting high order aberrations with scleral lenses. Indications: visual rehabilitation, also for the management of ocular surface diseases, dry eyes, etc., and for therapeutic options in some cases. And here, just a curiosity, here we can see Tom Cruise with the scleral lenses that was fitted during a scene of the movie Mission Impossible 5. Where he needed to have his eyes open during a scene with very wind, and so to protect the eyes from a fast dry, they fitted a scleral lenses for him to be able to open his eyes during the scene. So scleral lenses are also famous in Hollywood. So we were talking about the indications. And let's see the potential contraindications. So it is important to keep in mind that there are some potential, okay, and emphasis on this word, potential contraindications, like the low endothelial cell density that could be related to many factors, endothelial dystrophies, age, diabetes, also post-corneal transplants. And in those cases, where the endothelium is not it's altered, scleral lens wear could exacerbate the pre-existing corneal edema. So if we need to fit sclerals in these cases, it is very important to photo document everything prior to lens fitting. If you have a specular microscope, yeah, perfect. So you can have the changes in the corneal endothelium through time. But if not, okay, just photo document and be sure that the fitting is correct to avoid any problems with hypoxia and corneal oxygenation. Also, you can reduce the number of hours of lens wear, head fenestrations to have more tear turnover or tear exchange that will promote more oxygen to the corneal surface. But yeah, this is not a true contraindication. It's something that we need to take more care in the fitting. About glaucoma, so we have to manage when we have drainage devices for intraocular pressure like this one. So sometimes you could need to do a notch in that area. And also here is not glaucoma, but about the intraocular pressure. So there are many studies that are studying the effect of scleral lens wear on the intraocular pressure. The studies are a little inconclusive, but it seems like when we are with the scleral lens on eye, there is an increase in the intraocular pressure. And we can see here in these images, OCT images, we can see why. Because we have here in this image, right after the insertion of the scleral lens and after 1 hour. And you can see that there are some tension lines here, and near the Schlem canal, so that is responsible for the movement of the aqueous humor in the anterior chamber. So yeah, this is something that needs further studies, because it is very difficult to measure the intraocular pressure with the lens on eye. So we can measure before and after scleral lens wear, and with the lens on eye only with transpalpebral tonometers that could not have enough precision for these measurements. And another potential contraindication is overnight wear. So for irregular cornea, we can say that this is a contraindication, but there are some cases where it is indicated to wear the lenses through time, like persistent corneal defects, etc. So when we fit scleral lenses for continuous wear, so here the risks-benefit ratio, but in these cases, The scleral lens protects the ocular surface and helps the eye to heal or to heal faster. So yeah, something to take into account. And of course, because scleral lenses land on the sclera, we need to know the shape of the sclera. So we need to think in this case not outside the box, but I will show the results of some studies that measured the asymmetries, and we can see that near the limbus, the asymmetry, there are the values of the tangent angles, so in the limbal area, are very similar across the different meridians. But when we move away from the limbus, we start to see very asymmetries. So we can see that the inferior and nasal areas have smaller tangent angles. That means that these areas are flatter, and this will have some implications. So probably we'll need special geometries in the landing zone to align the lens with the sclera. Also, where we will have big asymmetries the further we move away from the limbus, and this can have some implications in the decentering of the lens. So the lens will decenter a little bit for the temporal side because the nasal area is more elevated or more flat, and also inferior decentering, but this because of gravity. And okay, so we have this study and another study that is in your right side. So they assessed several sclerals and they divided the pattern of the sclera in 4 different groups. And they found that only 6% of the scleras that they evaluated were spherical, and most of them were quadrant specific, so were irregular over the 36 degrees. And so some have had some regular toricity on it. Now, let's move into the step-by-step fitting without advanced technology. So this was an introduction because it's needed for those who never fitted scleral lenses to know about the implications of the things that I'll be talking in the next slides. So step by step, there are some steps, and we will start with the selection or more the evaluation of the patients for the scleral lens fitting. But now let's think about a keratoconic patient. So imagine struggling to see like the bus numbers on the street, missing the details when seeing a movie or working in a computer screen, or even being forced to leave the dream job or the dream studies because of the poor vision. So, and simply daily tasks will become very challenging for them. So can you imagine the suffering of these patients? I will put emphasis on that because the empathy that we show for the patients, so it's very important. We need to understand what they are feeling and create some bond with them. So this is the thing. Technology will not build this trust that empathy can build with the patient. So for a successful fitting, forget about the technology. We need to empathize with the patient, to have knowledge about the ocular surface and have those equipment that I told on the beginning, so slit lamp fluorescein and trial set of scleral lenses. And about empathy, me, Daddy Fadel, and Lisa Barnett, we did an online survey, and there are interesting things about the empathy in the contact lens practice. So in this study that is published on the Journal of Contact Lens Research and Science, we concluded that optometrists scored higher than ophthalmologists in the measuring the patient satisfaction related to the empathy that the practitioner had. And related to this study, also I present in GSLS 2 weeks ago this poster, along with Adi and Melissa as well, where we studied the influence of the gender in the empathy and the communication with the patient. And it seemed that female physicians received higher ratings in the empathy-related aspects. So, yeah, probably female physicians will not need to practice empathy if it's possible, but those who are not females, please try to take this into account and be more patient with your patients. Oh, keratoconus has a big impact on the quality of life of the patients, not only on the quality of vision, but in a different perspective, we can save their lives or their vision with scleral lenses, as many studies have shown that when we fitted patients with keratoconus and other corneal irregularities with scleral lenses, we are improving not only their quality of vision, but also their quality of life. So moving on, so we have done a complete analysis to the patient, showing empathy for this situation. So building trust with the patient. Now we need to go to the more optometric things. So we need to have a baseline evaluation of the ocular surface with slit lamp and with fluorescein. And this is important to identify the patients at risks that and to treat and to manage that ocular surface disease, if possible, or try to minimize the outcomes of that ocular surface disease that could have in the fitting. Also, with slit lamp, we can see this eye profile. We can do this with the slit lamp, and it could be difficult in the first times, but with experience, this will allow you to see, okay, this patient probably will need a lens with a higher or a lower sagittal height, depending on this corneal profile. So it will help you maybe to select the first trial lens for that patient, and make the fitting going faster. So you probably will need to require less trial lenses to achieve the best optimal fit for the patient. And okay, now entering in the selection of the trial lens. So how to select the diameter? Yes, follow manufacturer guidelines. You can have the HVID for a baseline assessment and to select the lens diameter. Also consider everything about the anterior ocular surface of the patient. So the palpebral aperture, if the patient has ocular surface disease or not. So if there is an ocular surface disease, we probably should increase the diameter to provide a better ocular surface protection over a more extended area of the ocular surface. If we suspect of highly asymmetric sclera, and I will show you in the next slides, maybe at the end, how can you suspect that a patient can have asymmetric sclera. So in this case, opt for a smaller diameter because it will help you in the fitting. So if you remember the slides where I show you the scleral toricity, I show you that near the limbus there was a more homogeneous scleral shape, and the asymmetry begins as we move away from the limbus. So if we suspect that the patient has a big, highly asymmetric sclera, go near the limbus. Also, advanced keratoconus, probably we will need increased diameter to have better clearance and stability on the eye. And yeah, so when we have another things like presence of pinguecula, we need to adjust the diameter to avoid interference with the elevated areas. So if the pinguecula is near the limbus, we can have more big lenses to pass through this elevated area. But if the pinguecula is far away from the limbus, we can have smaller lenses and to not touch that pinguecula. Of course, we can also do or ask the manufacturer to do some customizations like a peripheral vault to vault over that elevated area, or doing a notch that is something like that. And you can ask this to the manufacturer, or you can do it yourself if you want. Of course, as a researcher, I will tell you to ask to the manufacturer, because when you are modifying something on a lens, this is something that is off-label. So yeah, some problems with that in some countries. But you can ask the manufacturer to do that. So these are the things about the lens diameter that we need to take into account. And as you can see, there are no advanced equipment here to select the lens diameter. About the sagittal height, so usually the manufacturers have some recommendations. So if you have a normal cornea, use this as first trial lens. If you have advanced keratoconus, use that one, and you can follow that manufacturer guidelines. Also, empirical observation, the things that I told you earlier. So yes, it requires experience, but if you start right now doing this in all your patients, you will be able to understand when you will need a higher sagittal height. Also, corneal topography can help you. And I'm talking about corneal and not scleral topography. So corneal topographers are more accessible in the clinical practice. And yeah, this should help you. And why I'm telling you this? Because in this study from the Pacific University, Patrick, Caroline, and colleagues evaluated the sagittal height of the sclera. So don't taking into account the corneal part. And they concluded that the scleral sagittal height was very similar between eyes with normal corneas and eyes with keratoconus. And they end up with something like this. So you can do a corneal topography and then extract the sagittal height of the cornea for a 10 millimeter cord length, then add the scleral factor that is about 200 microns, as you can see in the images, and then also add the initial tear reservoir thickness that you want, so 300, 200, 400, etc. And then you will end up with the sagittal height of the lens that you need to apply. But these calculations are for a 15 millimeter lens. If you have here, so if you want a 15.5 millimeter lens, you need to increase 200 microns in this scleral factor, etc., etc. But this could help you in some cases, but in others don't. And why? See the range in the value. So the mean value is around 200 microns, but there is a big range. So some people have 106 and others have more than 2000 microns. So yeah, if the patient has a ocular surface that is in the mean values, okay, these will help you. But for those who don't, this could not be a good thing to take into account. Now, another question to you about this, how to select the lens periphery. Which periphery design should I choose for the first lens? What do you think? We should fit a toric landing zone or a spherical landing zone? So no one is choosing the spherical landing zone. Okay. Thank you. Someone chose the spherical landing zone. Maybe the toric landing zone will be the best option. As we saw in previous slides, we only have 6% of spherical scleras in the world, or we should expect only 6% of our patients to have spherical scleras. But when you are an experienced, putting a spherical landing zone first will not be a bad thing, because when you put a spherical landing zone, you will understand the shape of the sclera of that patient. You will see if the patient has a toric sclera or a regular sclera. Okay, so if you put a spherical lens on the toric sclera, you will see some blanching in one meridian. But if it is an irregular or a quadrant specific type of sclera, you will see blanching in only one zone, etc. So putting a spherical lens first is not bad. The only thing that is bad is that probably you will need another trial lens after that, because a spherical lens will not be the perfect one for that patient, but it can help you understand the scleral geometry of that patient. So we talked about how to select the lens diameter, how to select the sagittal height, and how to select the landing zone. And now, okay, we selected our lens, and now we need to insert the lens on the patient, right? And this could be a nightmare sometimes, because we need the patients to have the eyes wide open, because the scleral lenses are big, but it doesn't happen that way. So yeah, we need to educate the patient to open the eye correctly, and we can insert the lens either with this hands technique with a 3-finger, and the lens will for the liquid that is on the lens to not fall, or with a plunger, as you can see here on this video. And there are, as we saw, there are a lot of things that could help in the insertion of the scleral lens. There are stands for the plungers, etc. So this study is very interesting. It illustrates what happens to the patient anxiety levels during a normal contact lens fitting appointment. So in this study, they measure the skin conductance levels through the consultation, and we can see that there is, so in psychology, the increased skin conductance is a psychological response triggered by when you are stressed. So this is not a measure of anxiety, but is psychological correlated with that. And from this graphic, we can see that there are like 4 stages which appear to be associated with increased stress levels. The first is when the patient is speaking, when he's in the anamnesis, then at contact lens insertion, and then at contact lens removal, and yeah, when we are talking with the patient with all that information that they need to know about the handling of the lens and the care of the lens. But it seems like when the authors also had a questionnaire prior to the visit, and the level of anxiety was 9, and it decreased to 7 after the visit. But this study was done with patients without any kind of eye disease. So is a contact lens fitting appointment for a patient with keratoconus, for a scleral lens? So they are bigger lens. So all these things could be exacerbated in patients with that condition. So we don't really know, there are no studies about that, but the levels of stress and of anxiety could be higher in those patients. So a nightmare for the scleral lens wearers and also for the fitters is that when we are inserting a lens and there is air bubbles there. And it can happen because of incorrect lens insertion, and the only solution is to practice. But this also can happen because of incorrect geometry of the lens, and we will see a video later on this presentation about that. And the solution here, of course, is to change the lens parameters. So in the work that we have done here in the University of Minho, we measured the time that the patients needed to apply a lens correctly for the first time. And taking into account the habitual correction that they had prior entering the studies. Of course, those that were scleral lens wearers, less than 15 minutes, so 1 minute to insert the scleral lens, of course. But when patients were wearing other types of contact lenses, namely corneal, soft, or using glasses or without prescription, some of them needed more than 60 minutes to insert correctly the lens for the first time, so without air bubbles. This means that these patients, this is not possible during one appointment, so these patients needed then more than one appointment to do that. And even when the lens were dispensed, some of them, we can see here, number of attempts to insert the lens that they reported at home. So in the first month, we can see that many of them could need 2 or more attempts to insert the lens correctly for the first time, but it will decrease over time. So most of them will put the scleral lens after 3 months on the first attempt. So this is a feeling when we apply the lens for the first time with the first attempt. Now let's move to the evaluation of the fitting. This is an inside-out approach. So first the cornea, then the limbus, and then the haptic zone. Remember, without evaluating the fitting without advanced technology. So we need fluorescein and a slit lamp, and it will help when we do something like that. It will help us to see if there is any touch in the limbus, any touch on the ocular surface, on the cornea. But we also will need to do an optic section with the slit lamp to estimate the tear reservoir thickness of the lens. And when we have fluorescein, it is very easy. We should estimate this thickness comparing this green area with the thickness of the lens, because the thickness of the lens is something that the manufacturers can give to us. When there is no fluorescein, yeah, you can of course see it, but it could be more difficult if you don't have enough experience. And in keratoconic patients, so this is not a static evaluation. You need to do to ensure that the lens is not touching in any place of the cornea. So we need to check all the corneal surface to see if the lens is not touching in any part. And we should not expect an uniform tear reservoir over the cornea when we have patients like keratoconus, etc. And this tear reservoir thickness needs to be evaluated after the lens fitting, after the lens insertion, and also after some time of lens wear. Why? Because this will decrease over time. This is well documented in the literature, so we all know that this will happen to our patients. Also, we should consider that during the 1 year of lens wear, this will also decrease a little bit more over time. But here, so during the day, it will decrease something about 80 microns, 100 microns, and throughout the months of lens wear, we are talking about 20 microns. So it's clinical less relevant. Also, because doing the measurements without fluorescein will be more difficult, many less experienced practitioners, what they do on the follow-up evaluations is to remove the scleral lens and reinsert them with fluorescein. But I will tell you, this is not a good thing to do because it will increase the sagittal, the clearance after we remove and reinsert the lens. So, things about the reservoir thickness: ensure that there is no touch at any part of the cornea. About the limbus, this is a very demanding area, so we need to ensure that the lens is not touching on the limbus, okay? And I think this is the most difficult part on scleral lens fitting when you don't have technology, because it is difficult to see sometimes that separation between the limbus and the lens when we don't put fluorescein. But if you remove the lens, the ocular surface will tell you everything of what is happening underneath the lens. So if you are not able to see the separation between the cornea and the limbus, remove the lens, put fluorescein on the eye, and the eye will tell you, yes, this lens is bearing here on the limbus. So this is something about the comparing the new prescribers and the experienced prescribers of how they judged what is a sufficient or insufficient corneal clearance or limbal clearance. And yeah, there are some differences in the judgment over time. I hope you to invite you to see this work because it's very interesting. About the scleral zone, we can have three things. Is the lens is well aligned, the lens is not well aligned, and in that case we can have conjunctival blanching if the lens is too tight, and this can be overall the landing zone or in some specific areas, and also in other cases we can have edge lift. So this is a case where I inserted a spherical landing zone scleral lens on this, and we can see here that there are some blanching in some areas, some of them because of this small pinnacle, etc. But yeah, there was blanching, and by doing that, I saw that this sclera of this patient was toric, so we fitted the toric lens and the fitting improved a lot. About the edge lift, this is not a bad thing. Actually, if it's something like that, so you can put fluorescein over the lens to see how the fluorescein enters the reservoir. So this is not a bad thing if the patient don't have midday fogging or don't complain about discomfort. Because it will allow for some tear exchange that is good for the corneal health. But when the edge lift is excessive, so you will have some air bubbles entering the chamber. And there are some images of blanching on the landing zone. And yeah, so I talk about that. So detecting cornea scleral toricity when inserting a spherical lens. And with the slit lamp, we can see when the lens is lifted, we can see this shadow here when we do a tangential observation of or tangential illumination with that device. And there are different patterns of tear exchange that we can see if we put fluorescein over the lens. So in some cases, the lens is too tight, so the fluorescein will not enter. And in other cases, the fluorescein will enter very easily. And of course, as I told you, even when you have some difficulty in assessing the fitting of the lens on the eye, please do that. Remove the lens and assess the eye with fluorescein on the slit lamp, and it will tell you everything that is happening underneath the lens. So if the lens is very tight, if the lens is bearing on the limbus, etc. So, what do you think this image shows? This is a flat landing zone, a steep landing zone. This is a good fit. What do you think? Okay, steep. Anyone has a different opinion? I have. When the blanching happens here on the landing zone of the lens, it is because the lens is flat on the landing zone. But when the blanching occurs near the limbus, it is because the lens has a huge edge lift, and the lens is bearing near the limbus. So it is because the landing zone is very flat and not steep in these cases. A steep landing zone will be something like that. Okay, in these cases we need to flatten the lens. In these cases we need to steep the landing zone for the bearing of the lens go through this part of the lens and not near the limbus. Okay, so one case report, I will go very fast through it. This was when I was just starting out. And yeah, please don't laugh at my case report, because yeah, it is very interesting. So it was a male with regular astigmatism, this limbus to limbus high corneal astigmatism, and he wanted to try sclerals. The idea was, of course, let's try sclerals without advanced equipment. Here we go, following the manufacturer's guidelines. And I was trying to insert the lens, and the lens popped out. And I was like, okay, maybe it's too flat for this eye. So I changed the periphery to be more tight, and the lens popped out again. So I was like, okay, I need the lens to be more, even more steeper. So I ordered the lens, another lens. So here I am only changing the perifactor, not changing the toricity or any other parameter, only the perifactor. And what happened? This happened. So there was blanching on the horizontal meridian, and on the vertical meridian, we can see some air bubbles entering. So case of a high scleral toricity. And the patient was starting to feel very anxious because, yeah, many lenses for them. And we needed to order another lens. And now I changed the toricity of the lens. And what happened? Horizontal blanching, the vertical meridian now was okay, but the lens was very decentered. We had a high clearance in this case. So yeah, we needed, the patient was not taking very happy with that, but we needed to order another lens. We decreased the sag, and we made some adjustments in the periphery. And what happened? It seems like that nothing happened. High clearance, lens decentered, patient with discomfort, patient unhappy. So this is sometimes the things that we need. Okay, we'll just give up. But then, yeah, we can rest a little bit and taking our knowledge to our practice. So we know that the scleral lens is asymmetric, and that asymmetry is higher as we move away from the limbus. So why? Let's try decrease the diameter of this lens. So probably the toricity of the sclera of this patient will not be that higher on the near the limbus. So I decrease the diameter, decrease the toricity, and decrease the sagittal height of the lens. And yeah, that was perfect. Okay, we only needed another lens order to adjust the refraction, because yeah, only when we achieve a good fit it is possible to do a good over refraction. And remember that when we have a toric lens, there are these marks that will, in most of the manufacturers, these marks says where the flattest meridian of the scleral lens is. And if you have a toric over refraction, you need to say to the manufacturer where is the lens, where is the flattest meridian of the lens. And why I'm telling you this, because this is an interesting thing. In this patient, the stabilization of the lens, so the flattest lens meridian, was at 20 degrees. That was very similar to the flattest corneal meridian. And in fact, there are some studies that say that when we have this kind of corneal geometries, that the sclera seems to follow that asymmetry of the cornea. So when you have something like this, some cases of high corneal toricity, remember that the sclera will also be toric, and probably with the same meridian, with the same flattest meridian. So to minimize all this share time and all these appointments for that patient, of course, that technology will help. But the patient was fitted without that technology as well. So remember that. It will help, but you don't need that. But this case is not ended, because on the next day, the patient was dispensed with the lens, was happy with the lens, and on the next day I received this photo. So the patient was with the lens on eye. This case is documented here on this case report. So the patient was with the lens on eye and doing some maintenance on the motorbike, and some piece got on the eye and broke the lens on the eye. But fortunately, it was there was no damage. So yeah, it's an happy ending. But it required another lens ordered. But yeah, the patient was happy because it was not fault of the clinician, but fault of something that he do on his daily lives. So this was a tough case for me. It was one of my first fittings, and probably that's why that I ordered many lenses to the manufacturer. But yeah, at the end, this is the feeling when you fit a case like that without advanced technology. Yeah, it's very rewarding. And in this study, so this is also a study of my PhD. When we fit scleral lenses by a trial and error process without advanced technology, in the great majority of cases in the beginning, we will need 2 trial lenses to achieve the best fit, in some cases more, of course. But with time, we will reduce this number of trial lenses and this share time when we gain more experience, and the same for the reorders to the manufacturer. So one key aspect is we need to avoid to apply many lenses for the patient, because it will be discomfortable for the patient, create inflammation, and all of that will lead to an inadequate fitting assessment. But sometimes we need to do that to apply more than 2 lenses. And in these cases, in some cases, it could be necessary to have more than 1 appointment to do that. So lens removal, we can remove it by hand. That is very easy, something like that. And with a plunger. And with the plunger, we need to ensure that the patient is putting the plunger on the lens periphery, like in this video, and not something like in this video that is available on YouTube. It is a guy trying to remove a scleral lens with a big plunger. That is not correct. We should use a smaller plunger and in the center. And yeah, that's perfect, right? But yeah, don't do that at home, please. And remember, plunger always on the periphery of the lens. So one thing that sometimes we think that the fitting is okay, but when we remove the lens, there is some rebound hyperemia. It will say to us that the lens is very tight in the periphery in the periphery, and in that cases we should change the fitting of the lens, or we can also ask the manufacturer to do some fenestrations that will release the suction of the lens. So we are ending. Key takeaways. So you've got this. Trust your skills and your problem-solving abilities, and please keep learning, study and talk with experts in scleral lens fitting to help you, and communicate with your patients. This is very important. So it is important that the patient knows that your way of fitting the lens is a trial and error process. So you should tell the patient that, okay, during this appointment, we will need to insert several lenses on your eyes, but don't worry, that is normal. That is the process, the normal process for that. And so the patient is counting on that during the consultation. And never forget to remove the lens and assess the ocular surface with fluorescein, because the ocular surface will tell you all the story. That was what is happening behind the lens. And remember that, yes, of course, the technology will help you, but it is not everything. Remember that you are the advanced technology that your patient truly needs. So your empathy will make the difference in their lives. So please don't be afraid of trying to fit scleral lenses, even without having any type of technology. And also don't forget to register for the next webinars at Euroschool. That will be very interesting. And of course, thank you for being here, listening to me, and I'm available for take your questions. Thank you.
Thank you so much, Ruth, for this very interesting presentation. So we were discussing this before this webinar. I loved her title saying fitting scleral lenses without technology, simplifying the fit. While what we usually say, if you use technology, your fit is easier. But yeah, I'm fan of technology. So who knows me know how I love technology. But I've started fitting scleral lenses where technology was not available for about 10 or probably 15 years. I fit the scleral lenses without any technology. I didn't even have a digital camera in my slit lamp. So all the pictures, some of these pictures that you have shown here in this presentation and in my publication, my book, they are taken with an iPhone 6 on the slit lamp. So what you need is only a stable hand, and that's it. You need slit lamp, an iPhone 6, fluorescein, and scleral lenses. That's all to start fitting scleral lenses. And yeah, It reminds me about Ken Pullum, who doesn't love scleral lenses, and he continues to say that we are complicating the fit with so many advanced design and many advanced technology. Fitting scleral lens is so simple. You apply the lens on the eye, look at it. What is the problem? Resolve it. That's it.
Yes, yeah.
So
And
your
actually,
scleral lens is your topography. The scleral lens on the eye is your topographer.
yes, is our scleral topography. Yes, of course. And also, I followed up in a patient, in a Portuguese patient that was fitted by Ken Pullum with a molding technology. And yeah, the patient told me at the beginning, "Oh, are you putting me more than one lens on the eye?" Yeah, and I told you, "Yes, yes, don't worry. This is the way we work here. Ken Pullum has different technology that we don't have here, but we will arrive at the best lens for your eye as well." And it went very well. The patient continues with me, so yeah, don't be
Fantastic.
afraid.
So we went a little bit over time. I have one
Yeah.
question in the chat, which is very interesting. Any suggestion for those who have a small eyelids opening for a diameter of 16 millimeters? So this is a problem of eyelid, but I have so many people ask me question, how do I deal with people who struggle to apply large lenses in their eyes? What would you suggest, Ruth, in these cases?
My microphone was off. So I will suggest to use a stand for a plunger, for the plunger. So there are many tools that will help you and the patient to insert the lens on the eye. So if you have a stand to the plunger and having the plunger there, the patient will have both hands free, and probably it can help him to open the eye more wider. And yeah, if that doesn't work, and I will suggest to decrease the diameter. But yeah, I think I don't like lenses smaller than 16 millimeters. But yeah, could be an option depending on the case. But in my practice, I do when patients have problems in inserting the lens, having a stand with a plunger helps a lot these patients. I don't know if it is your perspective as well, but for me,
Yeah,
it helps a lot.
you made a great point. Sometimes in these patients, your first thing is to reduce lens diameter, but you did a great, you made a great point that reducing lens diameter, you don't like it. Less than 16 millimeter, indeed, because you may reduce lens diameter, it will be easier to apply, but you will be touching the cornea or the limbus.
Of the
So
level.
that is, yeah. So this is not a great option sometimes. The lens diameter depends on the HVID. You have to hold the cornea, the limbus, and only the conjunctiva. If they have problems in applying a 16 millimeter, which is proper for them, you have to educate them properly and increase the number of session in applying and use all the devices that you have explored in this presentation. Okay, so thank you everyone. This webinar will be available online the next few days. We don't have any time for other questions, but if you want any more clarification, just write me the question and I will communicate this to Ruth, will put you in contact so you can deep more in this topic. Thank you so much, everyone, and have a good day for those who are starting the day and good afternoon for those who are in the afternoon or evening. Bye-bye.
Thank you.